But then people start taking these massive, broad implications away from clinical care. And they're like, well, I'm going to stop using this treatment. I'm only going to use this treatment based on a single paper. And the other scary thing about that to me is I know I can find 30 papers that say one thing and then one that says the contrary, and people will latch on to the one that says the contrary and go with that. It's always important, even despite my own opinions on it. I always want people to know that, hey, it might actually, this is what is thought, but it's not concrete.
Hey, eyes and shine there, my friends and colleagues, and welcome to the I Give a Damn podcast, brought to you by Fluorescene Media, the sim company behind ODs on Facebook. Today's episode is sponsored by Bausch & Lomb, Blink NutriTears. If you have not seen or heard of Blink NutriTears yet, Blink NutriTears is a new clinically proven supplement for dry eyes and is designed to help hydrate the eyes from within for long-lasting comfort. Developed with the expertise of both eye care and nutritional experts, Blink NutriTears features a unique formula of antioxidants, including that of lutein, zeaxanthin, vitamin D, and curcumin. And unlike many other supplements, it does not contain omega-3. As shown in a clinical study published in Frontiers in Ophthalmology, Blink NutriTears provided noticeable, continuous symptom relief within just 2 to 4 weeks. And it was able to do this by addressing dry eyes from the inside out, promoting healthy tear production and reducing patient discomfort. So, if you're looking for a first-line protocol for your dry eye management plan, then Blink NutriTears could be what you've been searching for. Blink NutriTears will be available both online as well as in the eye care aisle at most major retailers nationwide by the end of July 2024. Now, let's get back to the episode. And today our special guest is Dr. Cory Lappin, who clearly is extremely passionate and gives a damn about his profession and his specialty of dry eye, cornea, and anterior segment disease. And so I think any doctor who spends some time looking at the front surface of the eye is going to get a lot out of this conversation. So without further ado, hit those like and subscribe buttons, and let's jump into it with Dr. Cory Lappin.
First of all, really excited to be here. I've been looking for this for a long time. So yeah, as you said, I'm Cory Lappin, and I currently practice in Phoenix, Arizona, at Phoenix Eye Care and the Dry Eye Center of Arizona. Large, very medical-based clinic, but I spend the majority of my time really focusing on treating dry and ocular surface disease. That's always kind of been my big passion, and one of the big reasons, I even ended up in that clinic is I knew that was an area I wanted to really focus on. So yeah, it's given me a lot of opportunity to look at that, and then, just because the clinic, the dry side of things was started by Dr. Epstein, and he was huge in the optometry world, specifically with ocular surface disease. So just the opportunities I've had to work in that realm have been incredible. And yeah, like we've said, just, a real passion area for a lot of docs like you and myself. So it's been really cool so far.
I know I unfortunately never had the opportunity to know Dr. Epstein personally, but that is a great kind of honor to kind of walk behind his footsteps, because he did have a big landmark, and I've heard nothing but good things people have mentioned.
Yeah, I mean, he was an amazing mentor. I've been so fortunate throughout my entire career that I just have these really impactful people who have kind of, just helped guide me and get me to a place where I could not be more appreciative, and I'm just, again, very fortunate.
I'm curious how because early on in your career, it sounds like you knew you wanted to dive into this dry eye ocular surface disease. How did you even early on figure out that was your passion?
It was so funny looking back. This is a story I often tell. I knew as a student just based on what I saw, and it was you learn about all the different medical conditions you're going to be seeing with the eye, and then at the time we talked about dry, just some of the very basic things. I mean this is not too long ago, but just pretty much artificial tears, warm compresses, supplementation. But that was more or less kind of the long short. We had talked about LipiFlow, which was kind of the big new technology, Restasis, just very basic things. But what I kept seeing is from the time I started seeing students as a third year, one of the most common things I kept hearing was complaints of dry eye. But in a way, I almost felt like I was the only one hearing them. Like I kept hearing it, but I felt like no one was really doing anything about it. They come in, they're like, oh, here's your glasses prescription, here's your contacts. Maybe you give them a bottle of artificial tears, but that was really it. So that carried on. And even as a student, I got the sense, I'm like, this is a big thing. And I feel like no one is doing this. So then went on to my residency, and I was very lucky. I did it at Cincinnati Eye Institute. So the way it was set up, I was basically with a different subspecialty every day. So like Monday was cornea, Tuesday was retina, Wednesday was neuro. So I got basically exposure to a lot of areas of eye care. And then Dr. Bill Faulkner. He was a cornea specialist. He had retired from surgery, but he ran the dry clinic, and I loved working with him. It was one of my favorite experiences there. So that was where I first got my taste of being in a dedicated clinic to dry eye, and I absolutely loved it. And then my idea is, I really would like to work in a practice that's solely focused on dry eye and ocular surface disease care. Now, at the time, when I told a lot of our colleagues that, the answer I normally got was, that's a really dumb idea. And the reason why is they said, and this is funny looking back now, what they would say, a lot of them would say, there's not enough dry patients to do that. There's just not enough of them for you to do a clinic that just does that. Which you get that now. We say this, it's almost so funny, but that's exactly what I was told at the time. But it didn't discourage me because I know what I saw. I'm like, I'm not crazy. I know what I'm seeing. So then it happened to be I went to a dinner lecture, and Dr. Epstein was speaking at the time. And he always started his lectures the same way. He would say, hi, I'm Dr. Art Epstein, and I practice at Phoenix Eye Care and the Dry Center of Arizona, and I exclusively see dry eye patients. And I heard that, and my ears perked up immediately. I just felt very validated. I'm like, oh, see, there we go. We have someone doing this. So I briefly introduced myself afterwards. I didn't ever really do that. I went to many dinner lectures in my residency. We just chatted briefly, maybe for about a minute or so. He gave me his card. He's like, oh, if you're ever out in Arizona, stop by. So a few months went by, my residency was coming to an end, and I was looking at potential, where did I want to practice? And I'm like, okay, well, you know what? Send him an email out of the blue. I'm like, hey, I don't know if you remember me from the dinner lecture. I don't know if you guys are looking for an associate, but if you are, I'd love to come and visit the practice. Now, mind you, I'd never been west of Oklahoma at this point. I lived in Ohio my whole life, so he invited me out there. I went 2 days, and we clicked immediately. And that's how I ended up in that clinic. And it was just one of those moments in life where, again, I was so fortunate that we had that moment where we were able to meet, and it kind of sent me on that trajectory. And then again, he was a huge mentor for me in so many ways, both, clinically and then working with industry and everything. So, and then early on, some of my favorite memories with him were actually when I first started and I'm working with him in the dry clinic. And, when you first start out, your schedule's kind of slow. I remember just sitting in his office with him, and we would just talk. Talk about dry, talk about life, all kinds of things. And that was just, again, I think that would be all some of my favorite time where he and I would just discuss dry eye and things we were thinking and what we were seeing. And I would sit in with him, and we had so many ideas for the clinic. And that's right when we first got IPL. So we were working with that. So it was just really an amazing time that I'm always going to really cherish the time we had together.
With that world of dry eye, that's a big part. But you also have been involved in clinical studies. Mm-hmm. You've written a lot of not just lectures, but for publications.
Yeah.
Because that's a whole other step, right?
Yeah.
Many doctors just go to clinic and they see their patients. Fantastic. It's a wonderful way to live. But you've gone this little bit of extra step. Yeah. How did you start getting involved in that? Is it something that you really loved or knew you wanted to start doing?
So some of it was a bit by chance. I always really enjoyed writing. Always went all the way back to high school. I liked writing. I had a knack for it, but I pretty much thought, that was going to be done. Once I kind of went into the world of optometry and that, I'm like, it was great. I enjoyed doing it. And then basically opportunities came up. That, again, like I said, I feel like I've been so fortunate to have these little opportunities. It started with the writing, actually, with Eyes on Eye Care back when they were even new grad optometry, and they were kind of finding their way. Initially, they were doing things with residents, and Matt Geller, who heads Eyes on Eye Care, they were doing things this was at Academy in San Antonio, and they basically were saying, oh, you can come do this little interview, talk about a subject you liked. I'm like, oh, great. So I'll talk about dry eye. And I was very much at the time as a resident, my whole mantra was, if I have an opportunity, I'm just going to take it. So that was kind of my first foray into, working with Eyes on Eye Care. And, not too much after that, but then I know they started to go more into, okay, let's make guides to things. And they kind of put out, people have worked with them before. One, they were looking for a guide to ocular rosacea. Now, I always joke with them, the problem they had is they used the word the ultimate guide. So when I hear that, I'm like, okay, so this needs to be an exhaustive resource on everything about that. So, at the time, a lot of trade publications, things like that, there may be a little page thing like that. Mine, I think that one was something 40 minutes long when they did the read time on it. I did it, and I actually showed Dr. Epstein, and he's like, you're nuts. He's like, he was at the time, because that was so different than everything out there. He's like, oh my, he looked at it, he's like, this is insane. You put all this effort into it. And I'm like, yeah, well, I just wanted to do a good job. That was kind of what it is. I did it. I wanted it to be something I was proud of. Mm-hmm. So I did it. And it actually went incredibly well. And when they told me, they saw, because again, they were so used to these small pieces, but it really resonated with people because, and kind of like we were talking, with your YouTube content, you made something that was lasting. People could reference this. People could go and see, and they could learn from it. And then I started to do more of these guides. But basically, the way I did them, it's like, you have a literature review that you would go on PubMed and you see this. My whole mindset was I want to make a clinically relevant literature review, not just the information, but okay, here's what it is. Now here's how you go and use it. So I enjoyed it, and that kind of got the writing started. And I actually tell everyone who's aspiring, in this field, I'm like, if you really want to be a speaker, write first. Writing is how you can show people what you know and really kind of put it down in that. And it's there's a thought process involved in it. And for me personally, I really like writing. I know some people, as they kind of their careers evolve, they kind of transition out of writing because it's time intensive. It's very time intensive. And, they enjoy lecturing, things like that. But I think that's always going to be a part of my career I want to focus on because I just enjoy writing. So I was very lucky to have that opportunity.
I think the other benefit to writing, at least in my experience, is it's like a filter. Because you may know all this stuff really detailed in your head, but then when you try to start explaining it and teaching it, right? The old school, learn one, do one, teach one. Once you start trying to teach it or put pen to paper, whether it be an outline before you do a lecture or something like that, you start to realize what's important, when to kind of lead into things. Like, how do you build and really teach? And so I find I learn sometimes the most about a diagnosis, the treatment, by basically trying to reteach it from the ground up.
Yeah, 100%. I agree. I feel like every time I write, it's funny because people look at it like, oh my gosh, you know so much. I'm like, I know these things because I had to write about it. Like exactly what you said. It's like when you're writing, where you're kind of on the spot, you're like, I have to know this. It's not like you just talk about it. Especially that's why I'm like huge. I'm like on like citing, and I know you're very big on this too. If we make a claim, we need to be able to back it up with data. We need to be able to do this, and that's where I've learned so much. I'm like, okay, so what's known out there for this? And it's so funny because when I was in school too, we had a dual degree program. So I got my master's in vision science. So that was kind of my first foray into the scientific side of things. And it really was so funny. I'm like, I feel like that I didn't fully appreciate that until I started writing and then editing, because I'm like, oh, okay, I see now those skills I had at the time when I was still kind of learning that as a student now play such a big role that I'm like, yeah, I know how to do a literature review. Mm-hmm. I know how to critically analyze a publication, because you know as well as I do too, you look at a publication sometimes, half the time people read the abstract and they take away the key point, but then when you really dive into it, you're like, well, it's not really what it's saying. Mm-hmm. And that's where you get into the whole conversation of scientific literacy. So that I think really played a role into it, that again, I just really feel like even in recent years, I've really appreciated that side of things that I learned.
I think something else, and I'm sure you've seen this because you dive into those research studies. Yeah, you read the abstract and you even sometimes you look at the conclusion, you're like, oh my gosh, this is profound. But did you read the methodology?
Yeah.
Did you actually look at how they did the study? How did they select the participants for that study? And you end up realizing this study was crap.
Yeah, and it just, again, but that's what shows you. You look at the takeaways. People are like, oh my gosh, this says this. And some people are like, okay, well, what's the big deal? And I know you've seen this too. But then people start taking these massive, broad implications away from clinical care. And they're like, well, I'm going to stop using this treatment. I'm only going to use this treatment based on a single paper. And the other scary thing about that to me is like, I know I can find 30 papers that say one thing and then one that says the contrary, and people will latch on to the one that says the contrary and go with that. So you really have to take the body of this in totality. So, I mean, I think that's good, and that's what I try to communicate when I write. I try to look at that. I also try to be very transparent when I write about things. I'm like, okay, this is what's thought, or this is what's written. However, this is a controversial topic, because I think it's always important, even despite my own opinions on it, I always want people to know that, hey, it might actually, this is what is thought, but it's not concrete.
Right. And I'll share in the social media space, that's a big challenge that all evidence-based clinicians, doctors who are on social media, researchers battle, because oftentimes people who really know what they're talking about, really know the balance of the science, they can't make outrageous claims, and social media rewards the outrageous. So, someone's like, this one thing will fix and cure all of your problems. Those videos, those whatever people are sharing, those get hundreds of millions of views. They make businesses, they become so big. And that's easy to do when you're claiming just this one outlier study.
Yeah.
Right? But if you really look at the totality of evidence, it's not as clear.
Yeah, and I'm actually really curious. How do you feel like that has been for you? Because you've always been so great about that with your content. Because I mean, that, like you said, that's how this is, like social media. It's based off of clicks. You and everyone who makes it, they're like, well, you got to grab them. You got to, like you said, you say this outrageous thing. It's like, I mean, how often have we clicked on one thing where they lead you with something and it has nothing to do with the video, but they got you the click. And again, it's we'll be honest, it's not exciting to talk about, well, the data is kind of skewed, it's like, you're not going to get a click with discussing p-values, for instance. Yeah. But so how do you feel like that's been tough? Do you feel like you've been able to find a good balance between those things?
Thank you for asking. I know this isn't an interview about me, but this is something I've had to analyze over time. And there's sometimes I just know, hey, I'm going to do this topic. I know it's not going to get hundreds of millions of views, but I know that it is necessary for the public to find it. And I know there's people who see this problem in social media and they're seeking out evidence and they see that value. And usually it's like, hey, this may not get 100 million views, but the people who watch it, it's going to be extremely valuable for them. And they're going to be more likely to subscribe, stick around for the channel, support me over time. And those are really where the true value of having a good, valuable subscriber versus just numbers.
Yeah, you just get the one person that watches your one video. Yeah, I could see that. I think that's great to know. And I think, again, that's basically for you setting a good example for, there's a lot of medical influencers now. I've talked to students, and I know you see students all the time. It's definitely part of that, and it's in optometry, it's in everything. So I think for all these younger docs who definitely want to be in this space, I think it's good for them to have role models who they'd see like, hey, yeah, you can still provide good clinical, information without having to sacrifice, what we do.
And you do have to, that's part of the game. You have to find some way to get attention. Mm-hmm. So there is this level of clickbaitiness where I will spend full day thinking about just how do I title this video I'm going to do on this topic? Mm-hmm. What's the thumbnail going to be like? Because it's like a billboard. You need to get people, if your title is bad, your thumbnail isn't very good, people are going to scroll right past it. They're not going to care. So there's at least enough to get people to click in, but then showing up and delivering factual information in like a story explanation. I'm not perfect at it. I've learned a lot. I made a lot of mistakes along the way, but thank you for asking that, because it's a different part of scientific healthcare information that I think isn't really discussed, and a lot of people don't realize how big of a part it plays.
Oh, absolutely, yeah.
So going beyond that, back to kind of we were talking about dry eye, ocular surface disease. One big thing is that you have a good, like you're pretty young in this profession in this subspecialty, but you've grown really well in all of this space because again you do all that research and you really are passionate into it. So I feel like you have a good kind of thumb on the pulse or finger on the pulse of what's going on in ocular surface disease, dry eye. How has it changed, do you feel, over even the last few years?
It's been rapid. And I tell many people, I do think for us, we're going to look back probably, near the ends of our clinical careers. And I do think this will be kind of seen as like a golden age of dry eye and ocular surface disease care, mainly just because it's transformed. Mm-hmm. I said, going back to when I was a student, we had very few things. We went from primarily like home-based, very palliative treatments, not really addressing the underlying side of things, to now where, in my mind, I do think eventually we are going to see, I often now use dry eye and ocular surface disease interchangeably because dry eye it's an overly simplistic term from an antiquated understanding of dry eye, but we have it makes sense, it's always going to be there. But really, I think we're going to eventually see an evolution where ocular surface disease is its own specialty. I think it has to be. It's so complex and everything like that. And I think part of that is our understanding has evolved. We now understand that, again, going back to dry eye, it's not, I'm not producing enough tears. That's vast majority of cases, that's not what's going on. But because of that understanding, we've now also seen more treatment options available. And, so we went from having just classes of basically, a lot of anti-inflammatories, immunomodulators, and now we have different classes. And that's why I talk about all the time, which I think is so exciting. We're almost, when I discuss this with other doctors, I'm like, it's almost more like glaucoma now. You have different medications with different mechanisms of action. So people don't really question if you're going to be, okay, this will impact outflow. This is going to increase, it's going to affect aqueous production. So now we have ones where, we have immunomodulators for inflammation, but we also have things that can stabilize the tear film. We have neurostimulatory treatments. We have all the biologics. So we now are addressing the different mechanisms behind dry eye. And we've kind of discussed this before, and you have to address every single one of them. Like, you have to make sure you have that. And I think that understand it's coming. And then we also have in-office procedures. So we started with LipiFlow, which I say was kind of like the beginning of that. So that kind of kicked things off. But now IPL, and I just added radio frequency, and the results have been phenomenal. And just seeing the impact of those in-office procedures with all our different prescription medication offerings, it's exciting, and it's easy to be passionate, and it's easy to keep learning. And I think that's why I'm so excited, and I really like industry work because it makes me stay up on top of everything. I stay involved. So I'm like, oh, hey, this is coming, because so often I'll sit with my patient and I'll tell them, I'm like, okay, this is what I want to use for you. It's not out yet. This is what it's going to do. So I'm like, I'm waiting, and we have these discussions, but like, I'm able to kind of stay on the forefront of that because I'm waiting, because I know, and I think that's just going to keep building. I mean, there are already so many things in the pipeline. So I think it's transformed from kind of almost like this sub area where, you could like tack it on to an end of a comprehensive exam, where now that's why I tell everyone, never even attempt to do that. Like, it's in its entire focus, it's an entire area. And my gosh, patients need it. I mean, I know you've probably seen that too. They come to you and they're like, I didn't know there was a doctor who's going to focus entirely on this, or I would have come here long ago. So I think our perceptions are changing, our treatment options are changing. So it's just a very exciting time, and I think we're going to continue to see dry and ocular surface disease care grow.
And I think, like, in many ways, I feel like it's almost more complex than glaucoma is. Yeah. I think it's, some ways I've described it to people who aren't in the eye care world, is that it's kind of turning into the way cancer or oncologists have to manage things, because cancer isn't one thing, right? There's so many different types of cancer because of the different proteins or different genetic things that are going on. And so that's why there isn't just a magic cure for cancer.
Yeah,
it's like there's,
we're not going to cure dry eye the same way. Like when someone says, there's a cure for cancer, it's which cancer, which subtype, which genetic signature.
Right. How do you respond to that? It's extremely complex. And I think when I finished my schooling, I knew there was complexity to dry eye, but in my head, I was like, I've only got a few tools to treat it. It wasn't too much to it. So I stumbled into my love for anterior segment ocular surface disease and dry eye because I was kind of pushed to be like, oh, wow, my mentors at this clinic, they really know dry eye. Mm-hmm. And they have all these tools. Like, I really have to relearn, teach myself the understanding of the intricacies. And so, thankfully, I basically reread Dues and Dues 2 when that came out multiple times.
And it's a good point with that growth I was discussing. It's because I feel like that education is still trying to catch up, because we've had all these things, and even now students, they learn more than when we were in school with it. But still, it was interesting because the recent, I had a patient, and no one ever asked me this before, but I'm like, this was a really good question. A lot of our patients, just because we kind of have that referral center for dry eye, most of my patients probably seen about maybe 3 or 4 doctors before they get to our clinic. And she had asked me, she's like, so how much of this, all this dry eye treatment knowledge, all this, how much of this did you learn in school versus on your own? And no one had ever asked me that, but I'm like, that's a really good question. And I'm like, maybe like 80% of it outside. And that kind of, but then so many things clicked for me. I'm like, I mean, that's why it's an excitement area, but I feel like that's why it's still growing so much, because again, there's a lot of, like when you said you had to go out and seek this information on your own, that's this path isn't one that, I mean, and that's like all of eye care. That's optometry, that's ophthalmology. I feel like this is an area where it's not part of core teaching to the extent that we now understand it.
Right. And I think that's part of, education. They give us the tools, the fundamentals that we need to know. Like the old medicine, And then some of the newer medicine, we have to know those things to be competent, to be, to give us that legal ability to start practicing, but to really excel and start diving into these advanced things, it takes some work.
Yeah, and that's where, again, it's kind of, the whole lifeline learning thing. And that's kind of what I even encourage students. I'm like, when you're in school, more than anything, you need to learn how to think and learn. Because, again, things are always going to change. So those, again, like you said, it provides the foundation, but they're also giving you this tool set to be able to find these things, to be able how to think, because you can translate, like we were saying, like the same mindset used to treat glaucoma. Okay, you understand a stepwise approach, you understand the different elements to it. That can translate to things like dry eye. It's like, okay, you know how to manage this complex thing. So now use that ability that you learned from that and just transfer those skills over to something different. And that's really what I encourage people. And I don't know if you've noticed this too. A lot of times what I've seen is it's younger doctors, if a clinic is going to start a dry clinic, they're normally tasked with doing it. I have many friends who reached out to me afterwards, a lot, especially my friends who are like co-residents, things like that. They join the practice and they're like, okay, yeah, I'm in this private practice and the doctor I'm working for wants to start a dry clinic. And they told me, okay, go, you're in charge of it. And they're like, where do I start? So it's definitely, I think, an area where we're seeing a lot, especially younger doctors, kind of being tasked with taking up that responsibility.
So with your wealth of knowledge in ocular surface disease, we've talked before, like privately, about like lifestyle and this impact of, how dry eye is so prevalent. And it seems like it's becoming more prevalent. How do you feel lifestyle factors are influencing this problem of dry eye?
It's huge. I've actually got to the point where I say dry eye as we know it now, I call it the disease of modernity. So if you look at the traditional dry patient, it was a postmenopausal woman. Mm-hmm. I mean, look, especially anything written before 1990, that's what you're going to hear. We know that's not the case now. And when I say I view it as a disease of modernity, it's because think of how our visual system was primarily basically how it developed. Ancestors were hunter-gatherers, so 90% of our visual world was distance-based. Predator, prey, you might be looking up close for a short duration of time, especially before written language and literacy had this impact. It might be, looking at tracks up close, might be examining something like looking at berries on the bush, something like that. But again, we were distance-based creatures. And that changed very rapidly. We had the invention of the printing press, the Industrial Revolution. So we went from where, again, just throwing that percentage out there, from a 90% distance visual world to now, you could argue probably 90% of our world is within arm's reach. So when we look off into the distance, depending on what study you look at, we blink anywhere between about 16 and 20 times per minute. And it can drop all the way to 4 or less when we look at anything up close. And again, I always think of it from the perspective of how did our visual system adapt? Anything we hold up close, our brain is going to deem important information, or why else are we going to hold it up close? So if you're, really scrutinizing something, the last thing you want to do is be blinking all the time. You blink all the time, it's going to obstruct your vision. So our bodies, I will say, are smart. They kind of know what they do. So I'm like, okay, let's kind of suppress the blinking. But now instead of a few seconds to a minute, we're doing it for hours on end. So our body's like, hey, I need to blink, but I still need to focus on this visual task. And it fundamentally alters how we blink. Mm-hmm. We now not only blink less frequently, but when we do attempt to blink, we often get partial blinks because our body wants to, but we don't obstruct the vision. So it's like, fine, I'll compromise. Lids will come together this way. But our blinking ability is intrinsically tied to secretion of our tears and just the renewal of that tear film. But we're training ourselves to do these incomplete blinks that even carry over when we're looking at distance again. So that's starting to lead to all these issues when we see with digital device use, because a lot of people, they know, they're like, oh yeah, using my phone bot, it's not great for my eyes, but they're not really sure why. And it's because we're just fundamentally changing how our eyes are being used. And that's why we're seeing now dry eye in younger and younger patients. And and it's also funny because this is just anecdotal. When I see a lot of my dry eye patients who are older, when I look at their meibography, their meibomian glands are normally, in most cases, in decent shape. But my younger dry eye patients tend to have way worse meibographies. And like each generation, I'm like in every successive generation, I'm seeing it like more and more and younger and younger. Millennials, more so there, but it's a lot of Gen Z. And once Gen Alpha gets there, I feel like it's just, that's when the tsunami's going to crash down. Because with millennials, I refer to us as more of digital pioneers. where we kind of remember that split, the before and after. Like, we remember payphones, we remember dial-up. So we kind of had that transition phase where Gen Z were they were the first digital natives. Like, they had it their entire life. And then Gen Alpha is just going to be even beyond that. So we're seeing that demographic shift. I'm sure you're seeing it, and it's a big thing. And when you say lifestyle, that's really what it is. Our screen time has just fundamentally changed. But here's the big thing too. That's not going away. It's not like people talk about this. I'm like, we're not going to change. Like, this is a change that is now so societally ingrained. We have to figure out different ways to manage this and live with this modern societal change, because we're not going back.
And I think, again, going kind of even to the fundamental of like what's going on, right? If we're not blinking completely, the eyelids are not closing, and then your meibomian glands aren't engaging. Your eye is constantly exposed to air. You have desiccation, you have hyperosmolarity, kicking in the inflammation, and then this whole cascade is just cycling all the time.
Yeah, and again, now we're seeing it in people who are 13 years old. And that's the other thing I've seen. The amount of like capping on the meibomian glands I'm seeing in kids now is insane. Like I that's something I'm like, this is, and the thing is though too, especially because they're asymptomatic. That's almost the scary thing, is that you're seeing already these signs manifesting. And I see that, I'm like, my gosh, you're 12 years old and like half of your glands are already clogged. By the time you're 20, my gosh, like.
Could you imagine the corneal, if we could image the nerves?
Oh.
The corneal nerve change?
With that, it's I'm glad you bring that up, because to me, that's like where I've probably spent more time, is looking into the nerves, the past year, than any other part of the ocular surface, because that's kind of our next frontier. Like, we understand things there, but like you said, with that, the nerve changes, and then even going to the symptomology of things, how many of these kids are going to get to the point where, they have some degree of reduced sensitivity at that point? So you're going to be seeing all these manifestations with even, maybe relatively to little, no symptoms, which most people, oh, that sounds great. Well, it's not bothering me. Yeah, until your entire ocular surface starts breaking down.
Right. And that's, I'll raise my hand, that's largely my story. I started having dry eye problems in my late teens, early 20s, because I was a contact lens wearer. And then before that even, I was a mild video game addict. Like, I played a lot of video games growing up, and I didn't blink. I didn't blink enough or completely. I still don't. And I know that I have largely a desensitized eye, because we do dry eye testing on me in the clinic, on myself. And it's a concern that I have for my patients, for young ones.
Oh, yeah. Yeah, it's funny you mention that, because again, we're of the same cohort, because I have the very similar story. Like, I started wearing my contact lenses when I was 12, and I had no problems with, I wasn't even aware I had eyes until I got into optometry school. And it's like, I woke up one day, I'm like, I can't wear my contacts anymore. Like, it was like I was just getting, it's like, and and it's a story we hear from our patients, so I had it too. And it's like, which was been part of my own thing. I tell the patients, like, yeah, I have dry eye myself. And like I've had to learn, for me, I can still wear my contacts. I'm like, I have to find the right contact for me. I have to do the same routine. Same thing, I grew up playing video games. I had done this. And now, same thing. I know if I'm writing on the computer for hours and I'm like, my eyes, I'm like, blink, you're not blinking. I know I'm not doing it. So like, I can, I get it. When I tell patients, I'm like, I'm right there with you. I stare at screens when I'm charting. I stare at screens when I'm working. So I know exactly what you're talking about with that.
I'm curious, because I from my knowledge, I think I've only found one study truly on like blinking exercises.
Yeah, I looked again because we had kind of discussed this. There's a couple out there. It's not a whole, it's not, I would agree, it's not like a robust body of literature. I still recommend it for patients, mainly if anything, at worst case scenario, it's going to at least make them aware of that. We all talk about the 20-20-20 rule, which is probably the most discussed and least implemented. And I always joke, because one of the tests that I do, I actually checks our patients' blink rate and looks at the partial blinks. And I always joke with them. I'm like, okay, yep, and here's your number of partial blinks. We remember those exercises we talked about that no one does. And they always laugh. They're like, yeah, they do it. So, I mean, there is evidence it can help, and it makes sense. So I always at least say, I'm very practical. I'm like, ideally, it's going to tell you to do it every 20 minutes, but no one ever does that. I normally say, I'm like, just try to shoot for maybe 3 to 5 times a day, mainly because my mindset is I want them to at least just think about that, to kind of be aware that like, okay, hey, if I'm on the computer for a while, I probably should make sure I'm at least blinking a few times just to make them aware. But like you said, not a whole lot, but at least what has been published has shown a positive effect. I don't know if I've seen anything, I don't know if you have, where they've studied it and it looks like it's done nothing. At least from that, but that doesn't always get published either. So I don't think in any way it would be harmful. So I think it's an encouraging behavior for, again, at least to get people thinking about it.
What about blink completeness? Do you think there's any way?
That's the.
I haven't seen anything.
Yeah, that's the tougher one because again, it's a lot of people. It's so funny. Even within the dry eye space, people talk a lot about blink rates, but I try to emphasize blink rates have not been, at least what I've seen, conclusively shown to impact dry eye. It's the incomplete blinking. That's again, because incomplete blinking is what's tied to the secretion of meibum and everything like that. So I don't know. I think that's something that would be good to see, is kind of get the complete blinks, because that's what I'm telling my patients. I'm like, I'm just trying to make sure that when you blink, you're basically training you basically subconsciously retraining the brain to bring the lids together when you're not thinking about it. That would be the end goal. Whether you can actually get that or not, that would be the hope for this. But again, I've talked to other doctors. They're kind of concerned on the flip side. If you get someone, constantly blinking all the time, especially with a dry ocular surface, is that going to increase irritation due to friction, things like that? So, I mean, that's why I tell people, I tell them, I'm like, I don't want you to worry about you need to blink all the time to the point where it's impacting your life negatively from that, but just try to be aware of it.
How important, we know medical treatments, we know the in-office procedures play a significant role of what we can do, speeding up resolution, helping patients with their symptoms. But how important is a lifestyle change or simple things like warm compresses, nutraceuticals, those sort of things? How big of a role does that play when you have conversations with your patients?
Yeah, I'm of the mind where every patient should have some foundational treatment. That's because again, I've been so fortunate. I have every treatment option available to me, but that doesn't replace the basics. I often, even when I lecture, when everyone's very excited about, the new and greatest thing, and I'm like, the way you're going to fail with this treatment is by ignoring the basics. So that's, again, there's differing opinions on this, but for me, I'm very much like, I'm really big on omega-3 fatty acid supplementation. I've clinically seen it work well, and part of it, I will say, it's from my own training. I was using it when I was a resident. I was using it with Dr. Epstein. I use it now. So for me, I've seen that. Again, when we talked about studies, we could talk about the DREAM study, and one of the worst design studies I've ever seen. But anyway, we won't go on that tangent.
Yeah.
But again,
I will mention the newer publication they had released earlier last year. I actually thought, I'm like, hey, they showed a significant p-value for improvement in the conjunctival staining.
Yeah, and it was another one of those studies where I felt like the takeaway was not what they found. Like, people were taking away, I'm like, that's not really what the study said. But for me, and then the other thing is too, there are plenty of studies that out there show benefits from omega-3 fatty acid supplementation. But again, then you have to dive into what's your EPA to DHA ratio, how much. There's just it's not as simple. And that's actually what I tell the patients. I'm like, it's not as simple as you just going to like the store and picking something off the shelf that's basically a fish oil supplement. It's a lot more to that. So I'm very big on that. Warm compresses, it's changed. I tell patients I think it can be helpful for you, but it's very self-driven. It's more of a palliative thing. You're not going to deliver the heat to a point where you're going to completely just liquefy the meibum. It's just not going to happen. But if you do find it comfortable, go for it. But then there are a subset of patients, my ocular rosacea patients, warm compresses actually make it worse. Mm-hmm. So I even tell, if I look and I see that telangiectasia, I'm like, have you done warm compresses before? And a lot of times they're like, yeah. I'm like, did your eyes get worse? And they're like, yeah, they got really red. I'm like, well, here's why. And actually those ones I tell them, I'm like, if you want to, you can use a cool compress. Mm-hmm. Like, again, because we're trying to look for comfort for this. So I'll have that discussion. Artificial tears, I call them a Band-Aid in the bottle. I say they're good to use. They're good for in a quick pinch when you need some comfort. Have them on hand. I think they definitely play a role for that, because that's the other thing. I find within dry eye care, some people can fall into extremes. Like, some people will be like, I never use artificial tears. I don't tell my patients to use them. And I'm like, I'm very pragmatic. All of us who have dry eye know, like, hey, there's a time I just want something to make my eyes feel better, mm-hmm. even for a few minutes. So I'll tell them, just have a good artificial tear. And I'm really big on lid hygiene. Mm-hmm. Personally, one of my ones I start for most people is hypochlorous acid, because mm-hmm. it's very gentle. It's the same thing leukocytes will use as an antimicrobial agent. I kind of explain that to patients, and I tell them it's just a general good practice, because well, one thing, if they tell me baby shampoo, I'm like, please do not do that. Please do not do that. So yeah, just those are basic things I really want every dry eye patient to be doing. And I tell them even, and then I'll offer things like, okay, we can also do IPL, because I'll offer it to patients as a first-line treatment even, because I've seen such good results. But I very much like for us to be in lockstep. I'm like, depending where you're at, I'm like, some patients like to start with the conservative things, see how they do on the basics, because that's my treatment philosophy. I want to keep them on the fewest number of treatments that will keep them comfortable. So if they want to start with that, that's great. Or if they want to be a bit more, proactive and they want to do some of these advanced procedures in conjunction with those, I'm like, let's do it. Whatever it is, I just want the patient, I'm like, here are treatment options available. What makes most sense for you?
And so I think that's all fantastic, because I feel largely the same way with a lot of those same recommendations. I think lifestyle is important to address because it often is even the root problem that kind of kick-started all of these problems for our patients, right? It's like it's taken maybe 20 years before you start to finally come in and start talking about this, but this started a long time ago.
Yeah, and I think and do you have that discussion with patients much? The big one I have with that is I always bring that up too, because sometimes when patients struggle is they don't know that this is going to normally take a while to start to feel better, because a lot of patients, there was one actually I had, and I kind of let her know, she's like, yeah, my problem is I keep seeing all these dry eye doctors and they start me on things and they're like, I'll see you back in about 2 to 3 months. And I was explaining, like, but the funny thing is, she said, it keeps happening. I'm like, well, there's a reason why. I'm like, the reason why is because, this didn't develop overnight. So it's going to take some time. Now, don't worry. Like, there's things I can do in the meantime if you're really struggling. Like, I can give you things to provide, temporary relief if we need it, but it's not the long-term thing. But the reason why I keep hearing this is because we know that this takes time to kick in. So just hold on for a bit and we can get you where you need to. That's why I would say we can get you where you need to be. It might just take some time. So don't be discouraged. We'll keep working on it.
I like to also talk with some of my patients in those kind of same mindset that your dry eye progression, you may be at a 9 right now. Once we get you below 7, your symptoms are going to feel better. But if you're at a 6.5, your symptoms are a lot better. You're not feeling any problems. It's still at a 6.5.
Yeah.
If you let go of your habits, your treatments, it's going to kick back into 7. It's going to take a while for that to come down that we get you to like a 3. And he told you at a 3.
Yeah. And it's funny though too, because a lot of my patients now, it's like, the thing I do like about dry eye patients too is they tend to be a very well-educated group, because they've been really seeking relief for this. And I have a lot of them, especially my longtime patients, they come in if they're in kind of a bit more of a flare, they're like, I was on vacation. I wasn't using my fish oil. I've been off my stuff. So they're like, my eyes bother me more, but like, I know what's going on. So they kind of already know. They're like, yeah, I'll get back on it and I'll be good. So there's not that anxiety that comes in. They're kind of like, yeah, I know why it's happening to me. And that's why I tell them, I'm like, yeah, you're going to be able to kind of track your own symptoms. You kind of know that. So once they do that, they very much get that concept of, that 1 to 10. They're like, normally I'm probably about a 4, 6 right now, but I've not been very good with my treatments recently.
I'm curious, since you practice in Arizona, being that it is desert climate.
Yep.
I imagine you have some patients who travel to like a humid climate. What kind of observations have you noticed in those patients?
So you're actually spot on. I see that a lot. I myself experience that. Like here, even right now, my eyes feel much better. Humid climate. It's amazing, the environmental aspect of things. And that really kind of goes into it. And Dr. Epstein often would use this terminology. We kind of would use the levels of environmental challenge versus what your eyes can handle. And in most environments, if you have a nice humid environment, you're normally pretty good. You go to Arizona in the desert, the environmental challenges are all the way up here. And I have so many patients who snowbird who go back to like the Midwest, they go back to the East, split their time there. And they're like, oh, yep, my eyes felt great. I come back within 2 days. That's for some reason, like about 2 days is when they know like, oh, yep, my eyes are red again. And again, their environments are more challenging. There's only one wrong piece of advice, and that's to tell your patient to move. And we laugh about it, but the number of patients who've come in who've told me they've seen another doctor and they said, well, you live in the desert. You're just going to have to move. I'm like, oh, yes, that's very easy. Just pick up your life, get a new job. But I'm like, I tell them, I'm like, I'm not going to tell you to move. I tell them it's my job to get you comfortable in this environment. Part of the reason why too, we have plenty of dry patients, but I really like the challenge of trying to do this. I'm like, because if I can manage patients in that environment, like it's like I could be able to translate this anywhere. This is like one of the, it's kind of, that's what a lot of us have when we're practicing this medical care. It's we kind of like to challenge the puzzle of all this. So I do always think about that, but it can make a major impact depending on where you live, humidity. A lot of times I actually tell people the worst times in Arizona actually tend to be summer, because the heat is obviously really, really high, but the humidity is actually a little bit higher for us in the summer. The winter temperature is amazing, but our humidity drops. And at night it actually gets a little bit cool, so people will turn on, like they'll try to get the heat on, and it dries even more. And then spring is kind of like allergies, but really it's those two. It's for Arizona, I tend to find people flare up a bit more in the summer and the winter.
And I think, at least in Minnesota, when I live in practice, the other component, because it's easy to blame outside. Oh, there's wind.
Oh, yeah.
The temperature, all those different things. In Minnesota, I'm indoors all day.
Yeah.
Air quality indoors. Like you said, the furnace is on.
Yep.
A vast majority of the year. I did about 2 years doing senior home care, and senior homes, they have the furnace really high. It's like 80 degrees, and it's just everybody has not just dry eyes, but they have dry skin, they have all these issues. And so that came to my mind. I'm like, wow, actually, and again, more people are spending more time indoors.
Have you noticed that? Because again, all my family's in Ohio, and my mom would have dry eye, and it would almost always be around October, and she's like, well, my eyes are bothering me again. I'm like, did you guys turn on the furnace? And it almost inevitably was that. Did you ever feel like you would see that?
Yes, absolutely. And I have to talk to my patients about that, just to bring their awareness to it. And they're like, oh, that starts to make sense.
Yeah.
Or they have a fan on, or they work at a desk job, but there's an air conditioner blowing right in their face.
Yeah, and that's the other problem indoors in Arizona. Everyone has to have a ceiling fan. We always have that. So we have a lot of nocturnal dryness issues, and they know it because that's what they say. They're like, yeah, in the summer we have to have the fan on, and it's just their eyes are just miserable with that. So yeah, those are just more of those lifestyle things. I feel like you kind of have to roll with the punches with the patient. You have to give them options for that, but I'm always one where, like you said, I'm never going to just blame it on that and be like, well, that's just the way it is. Right. Because that's kind of like the easy way out, and it doesn't really solve anything. I'm like, yeah, it's I'm like realistic. I'm like, hey, we're in a challenging environment. Let's see what we can do to get to the point where your eyes can withstand that challenge.
I think the one last kind of major question, just to kind of land the plane on this, because I know you and I are both passionate at this, and we could talk for another 2 hours.
Oh, yeah.
But the big question I love asking all of our doctors on the show is, if you were elected tomorrow as the Surgeon General of Optometry for all of the U.S., knowing what you could potentially do with making changes either for our profession or for the public good, for public health, what major change would you want to see and work on if you were in that position?
Really, I think it's just getting people to really understand how important, I mean, it's not anything profound, but how important our eyes are to our overall health. I often talk about, so it's funny because everyone, you've heard people talk about the dental model in optometry and everything like that. But what I try to tell people at times, I hear the dental model. I'm like, guys, this is not a novel concept, but what you have to understand about the dental model is that didn't happen overnight. The organized dentistry spent years of time and effort, public health initiatives, to get people to think of dental care as much as they did. We need to have the same thing when it comes to optometry with eye care. We need to have concerted, consistent messaging with this. We didn't, again, these were not, they almost sound like dentistry, this is how it always was. Everyone, it's like, I'm born and I know I need to brush my teeth twice a day and I need to see my dentist twice a year. No, this took a long time to really get that message out there. And for me, I'm thinking optometry and ophthalmology need to work together on that. Because I think that's the biggest thing, is I think the public only thinks about their eyes when there's a problem. And again, this comes back to, my passion with dry and ocular surface disease. It's going to be a public health crisis. It's already happening.
It already is.
Yeah, it's already happening. We're already talking about, with myopia being that, but dry is going to be, it's a public health crisis. So we need to get to the point where, we were talking about, for me, the foundational things for our dry patients. Really, those maybe should be things we should all be doing in a digital age. We need to be proactive about this. Maybe it's a good thing to let people know, hey, you should see your eye doctor at least once a year, maybe twice a year, but not just for the vision, not just, because that's the problem, is I feel like we've done a disservice by really kind of segmenting like, oh, well, yep, here's your refractive care and here's your medical care, where people are like, well, I only need to take care of my glasses. Like, that's like, if I can see or I can't see, but just letting people know that there's so much more than just your vision itself, but the eye health. So I would say if I would do that, I would basically say like we just need an initiative to people think not about just vision, but their eye health, and really start to maybe think we need to be more proactive, especially with these younger generations who are going to be facing challenges that we haven't before.
Right. And it just clicked in my head as you were talking about this. Like, I do spend time talking with like teenagers about cleaning their eyelids, because that's oftentimes when I start to see early signs of blepharitis, especially in contact lens wearers. And I remember, gosh, I wish somebody would have told me at a young age just to wash my face twice a day, which is like the Academy of Dermatology's basic recommendation for helping with acne.
Yeah.
Just wash your face twice a day gently with a gentle cleanser morning and night. That's what it says.
And think of what that would do.
Yeah.
Think of something that fundamentally simple. Yeah. And especially your contact lens wearers, you've already taught them to, take their lenses in and out, hopefully daily. That's not too much harder to tell them, hey, can you spray your eyes with a cleanser twice a day? I completely agree.
And so I think if we, as an industry, as a group, as doctors saying like, no, this is really good for not individual patient health, but for public health, for people to start doing this, and for children to start implementing this, because we teach our kids the value of starting to brush your teeth and hopefully floss too, but like how that could echo years down the road.
Yeah.
Like, just as to your point, it's going to take some time. But, well, Dr. Lappin, thank you so much for being here. Again, hopefully we'll have you on as a guest again in the future. But thank you so much.
Absolutely, thank you. I mean, this was great. Like you said, we could talk for hours. So yeah, we'll definitely do a part 2 sometime.
Well, again, thank you so much, and enjoy the rest of your expo here.
Thank you.
So that was our episode for today. Thank you so much for tuning in. If you are somebody who is deeply passionate about our profession or gives a damn about a specific topic that may be affecting our industry in some way, please let us know either in the comment section over on YouTube or in the review section. Leave us a solid review on whatever your favorite podcasting platform is, and let us know if there is a person in our industry that you would love to hear from, or perhaps a specific topic that you would like to hear in more of a deeper conversation on this podcast. Otherwise, thank you so much again for listening in. I hope you have a fantastic day, and we'll see you in the next episode.